All right, welcome everybody to the November CNS Journal Club podcast. My name is Haydn Hoffman. I'm a neurosurgery resident at SUNY Upstate, and I'll be moderating this episode. Today, we will be discussing an article published in Neurosurgery titled Venous Sinus Stenting for Low Pressure Gradient Stenoses in Idiopathic Intracranial Hypertension. I found this to be a very interesting, thought-provoking article that challenges a widely utilized exclusion criteria for venous sinus stenting in patients with idiopathic intracranial hypertension, and I'm looking forward to discussing it. With us today is the author of the study, Dr. Chen. Could you please introduce yourself?
Yeah, hi, this is Roc Chen from UT, University of Texas in Houston. I'm the one being registered doing this study.
Thank you. And we're also joined by our guest faculty, Dr. Waleed Brinjikji, who has published extensively on venous sinus stenting. I'm looking forward to hearing his take. Could you please introduce yourself?
Yeah, my name is Waleed Brinjikji. I am an interventional neuroradiologist practicing at the Mayo Clinic in Rochester, Minnesota, part of both the radiology and neurosurgery departments here.
Great. And we're also joined by Dr. Huang. Could you please introduce yourself?
Hi, I'm Dr. Kimberly Huang, and I am from Emory University over here in Atlanta, Georgia. I'm the CNS podcast co-chair, and very excited to talk with our guest today on an article. And my practice is actually quite different. I'm actually a tumor person, so Dr. Hoffman and I can learn, and the audience can learn a lot from our guest today.
Excellent. Well, thank you all for joining us. Dr. Chen, I really enjoyed reading your article because it really seems like you're expanding the inclusion criteria for venous sinus stenting, which, from everything I've read has been shown to be very highly effective and safe for a condition that can really be quite difficult to treat effectively. I think as neurosurgeons, we're well acquainted to the limitations of shunting with this patient population, and I think venous sinus stenting is an exciting alternative. Could you give us a brief summary of the paper and what led you to perform the study?
Yeah, as you have mentioned, that the medically refractory idiopathic intracranial hypertension has been frequently treated with venous sinus stenting at the stenotic, venous sinus stenotic portion with a high success rate over the last probably 10 years. Patient selection has been driven almost exclusively by identifying supraphysiological venous sinus pressure besides the neurological presentation. And the problem is that there had never been a single point that identified the true lowest pressure gradient would determine patients beneficial. As of this point, the vast majority of pressure gradient either is arbitrarily set or theologically we believe it's meaningful. So our study is intended to explore the probability of the lowest pressure gradient, venous pressure gradient, will benefit from venous sinus stenting. We use our single center perspective maintained the registry of a patient with intracranial hypertension, idiopathic intracranial hypertension, and including venous sinus stenting as the population for study, cohort study. We divide patients with the pressure gradient into three groups. The lowest pressure group determined is equal or less than 4 millimeter mercury, and the second group is a 5 to 8, and then higher than 8 millimeter mercury, which is the most frequently used, the lowest cutoff for the patient potentially benefit from treatment. And we look into the the outcome measure based on one, obviously, clinical improvement, symptom improvement, but mostly based on the rigid clinical objective outcome measure, which is our the neuroophthalmology evaluation, including optical coherence tomography, which is so-called OCT, visual field exam, acuity exam, and obviously resolution of the papillary edema. Among 53 patients in three groups together, the average, the clinical characteristic are very much similar. Average age 32, and then the BMI is about 36. The baseline characteristics is the same. We're looking into the outcome in terms of a lumbar puncture opening pressure at 6 months. Across board, three group turned a significant reduction back to the normal range. And the neuroophthalmological exam, including papillary edema evaluation, OCT, they all end up similar in terms of outcome. In absolute evaluation, it appear in the lowest pressure group, actually resolution rate of the papillary edema is 100% compared to the rest of it. These exam also shows on 6 weeks exam as well. So in conclusion, we believe that the patient with intracranial hypertension, with the lower venous sinus pressure gradient, seems also benefit equally with the venous sinus stenting at the stenotic portion as good as the high pressure gradient. That's what we're seeing at this point.
Great. Thank you for that summary. I'd like to open the floor to questions, and Dr. Brinjikji, I'd love to hear your take on the study and any questions you might have.
You know, I mean, I thought that the study was very interesting because it goes against the convention of kind of what I've learned in my training and in how I practice, and I love things that challenge our conventions. You know, one question that I had for Dr. Chen is, what are the, like, when you look at those patients that had a small gradient, you know, less than 4, you know, how severe of papilledema are we talking about? How severe was the IIH in these patients compared to those that have the really high gradients? And I'm just saying that based off my experience, you know, the patients that have the grade 4 or 5 papilledema, you measure the gradient, I mean, it's like 30, 40, 50. You know, but then like grade 1 papilledema, a little bit of headache, a little bit of this, a little bit of that, it's like 7 or 8. So yeah, if you could comment on that, I would love to hear.
I think that, and when we look at this, the headache and headache seems is one of the most difficult puzzle box, in the sense that the presentation seems that oftentimes not really directly correlate to the pressure gradient. That's my sense. Definitely in those patients with extremely high BMI, as well as patients that have fulminant cases come in with vision near loss in the crescendo deteriorate course, those patients, the venous sinus pressure gradient, as well as the lumbar puncture pressure, tend to be exceedingly high, like we described, easily go beyond 20 mmHg in venous sinus pressure. However, for the vast majority of patients with intracranial hypertension, we encounter on a daily basis more often a similar runs, often around, it really is run between 5, 6, 7, 8 to 10-ish. That's more common. That part, we really didn't see major differences. And papillary edema also, it's not exactly consistent with what we're seeing in the venous sinus pressure measurement. At the same time, even more so, that doesn't necessarily always consist with the narrowing, anatomical narrowing in the 2D angiography study as well.
Very interesting. And then just a quick, because so basically what I'm getting from this is that maybe, I mean, at least in a lot of these patients with smaller gradient, it's the headache that's driving the treatment. Is that correct?
No, actually,
oh, yeah.
no. In fact, this was started was because of these patients, and for quite long period of time, we never commit for that. We changed our algorithm over the few years of time. At the beginning, we always set our lowest margin of the treatment criteria is a 5 millimeter mercury gradient, meaning that 5 or below, we virtually exclude this patient from stenting. But as time when we realized that these patients remain to have a papillary edema, obviously those patients went for the BP shunt, but we realized that these patients at 5, 4, 3, they have every part of the clinical evaluation, objective evidence. We evaluate this patient not because of their headache. Typically, these patients refer from neuro-ophthalmologists. And after those rigid criteria being suggest that patient has a papillary edema, has OCT changes, then we perform LP first. If lumbar puncture pressure consists with evidence of a papillary edema and the visual change or visual field change, then we will proceed for 6-vessel angiogram and then determine whether they have an anatomical narrowing. And then from there, the last piece of puzzle is the pressure gradient. So without those criteria, the gradient measurement to us means nothing.
Okay. Great. And then another question, what you said that all patients, most patients had improvement in headache. What did you use to, comment to measure, headache severity? Did you use any scales? Or you just kind of just get a gestalt from the clinical notes and the interview?
So we have developed this questionnaire over the years of time. Every single patient from day one visit coming to our office or to the patient coming to the hospital emergently, this will receive a questionnaire and to check the headache, the level, which is scale from 1 to 10. But it's never really, I can't say those are always meaningful, but it is, on the other hand, in a certain sense, it is scaled for that presentation. And at the same time, also, whether they were on any medications for the headache, so throughout the time. So that also is additional, and how long has been seeing neurologist for the headache, all those included.
Great.
Very interesting.
Yeah.
Oh, sorry, Dr. Brinjikji.
Sorry, Dr. Huang.
No, it's okay.
No, go ahead.
Hopefully Christy can just cut that part out. So my understanding, and remember, I'm going to try to bring this back out for our general audience too, not just our vascular folks. So, for stenting for IIH, it's still across centers, and I hope you guys will will all agree with me that it's evolving in its indications and patient selection, and it's heterogeneously adopted. I think not all centers, I would say, are big adopters of it, and so. For the wider audience, I was wondering if maybe both of you could comment to the group, what's your institutional algorithm and indications for selecting IIH patients for, sinus stenting as opposed to more classic interventions like nerve sheath fenestration, shunting, weight loss, all the other options that exist for these patients, and how you sort of, talk about that to other institutions maybe that haven't adopted it as quickly as you guys have.
Should I go first? I'll go first. So I think you bring up one of a very critical question, and it's really important, I think, ultimately. Several things for us in going through algorithm. I think I agree that there are heterogeneous different criteria, but for us in our shop, we're going the following several algorithms. One is we start with patient presentation. Patient present with a headache and the visual obscurity. And these patients, number one, have to have the symptoms and particularly have been presented with the visual symptoms And these patients then typically will be evaluated by neuroophthalmologists. That include the standard battery, including the typical fundal exam, the OCT, Humphrey visual field, of course, the acuity. And those had to be positive that determine intracranial hypertension. Then the second, the objective element is LP. We do every single patient go LP by ourselves. That I'm sure Dr. Brinjikji will appreciate that. That is that under fluoroscopy, biplane, patients with mild sedation and with the in the decubital position instead of in the prone position, which is most neuroradiology would do the diagnostic element. And then once we access needle, we straight up a leg passively, patient without movement, we would do all this. And then measure pressure, and measure pressure only without drain any fluid. Measure pressure, and the procedure is done, that was it. Often, obviously, these patients often come with MRV. MRV will give us the first screening, doesn't give us the final answer. It gives us, if MRV shows perfect venous sinus, typically they are perfect. But in terms of there is a signal loss suggests stenosis, that might not be true. That all this together will bring us to the final objective evaluation, that is the cerebral angiogram. Anatomically, we want to confirm there is evidence of venous sinus stenosis. And from there on, as with study also to make sure, angiography study also need to make sure there is no dural AV fistula present. Often that will result in intracranial hypertension. And that's typical algorithm. From there on, we will determine patient will need for venous sinus pressure measurement. For us, we want these patients go through one procedure without additional venous access. So we typically schedule these patients with the during typalate planning 6-7 days later and check PRU, then proceed for venous sinus pressure measurement and the possible venous sinus stenting. That's what we typically do. And these will be done under general anesthesia. And that's the entire algorithm from subjective presentation and then complete all the objective evaluation and confirm the visual problem. Just by visual, just by symptom headache does not give us any venous treatment determination on that. The second part to answer your question is the weight loss. I never discuss any weight loss at the beginning of management. I don't. There are two things to me is critical. Number one, as you guys know, that any visual symptom presentation of papillary edema, it will unlikely to benefit from long-term the weight loss. This is not going to help and typically would continue to deteriorate rapidly. So that long-term weight loss is not going to help. Secondly, I believe that it is likely going to break down physician-patient relationship immediately. As we have done for the last 50, 60 years in terms of managing intracranial hypertension, as many neurosurgeons, including myself, encountered that those patients, we have little success in terms of bringing patient weight loss to the point. As long as still have a pain, have a problem, it's not going to go anywhere. However, it's been my routine. They will have an entire section of conversation with me at a 6 weeks follow-up after the treatment, successful treatment. So at a 6-week visit, I will go through a length of discussion weight loss, and then we'll refer them to visit one of our partner who, the bariatric surgeon, as well as his group of dietitian, consultant, trainer, everything. So that the time, and I found that's extremely successful. And that's how our algorithm goes. In terms of other penetration, those I didn't think that's been very successful. Often have been data suggests that the optic nerve sheath penetration nowadays from neuroophthalmology field suggests there is a potential crescendo deterioration after fenestration, particularly in the very rapid deterioration patient. So it's not very helpful, and have been shying away from that. And in terms of a traditional VP shunt, I have to say, over the time, over the last 7-8 years, I have not done a single VP shunt on the patients that refer to me for this. It's ionic, perhaps something to do with I dropped the venous pressure gradient level.
Interesting. Yeah. So there are some differences and there are many similarities between our algorithm and yours, and that's what makes medicine, beautiful, I think. So like for us, we only do venous. Every single potential IIH patient gets seen by neurology and neuro-ophthalmology. We always do a trial of medical therapy and weight loss with acetazolamide or topiramate. If patients do not succeed or fail medical therapy and weight loss, then they get referred for interventional treatment. Our ophthalmologists who also do the optic nerve sheath fenestrations prefer not to do optic nerve sheath fenestrations, and they're basically have rarely, if ever, done at Mayo. Shunting, we have not done any shunting since we started doing venous sinus stenting. So now if they do meet the criteria, they fail medical therapy, they meet the modified Dandy criteria, or some of the more recent criteria that was proposed in the Journal of Neurology, then and they fail medical therapy, then we proceed with evaluating candidacy for venous sinus stenting. Basically, every IIH patient is going to have narrowing of the venous sinuses on MRV. It's just, I've never seen a normal MRV in a patient that really has IIH with papilledema. We don't do an angiogram. We go directly to venography under conscious sedation with pressure measurements. And if we do see a gradient, we immediately proceed with stenting. So we basically do one procedure, a venographic study with a stent. And then we typically, have the dose of acetazolamide thereafter, do a follow-up visit at 6 weeks. One thing regarding the weight loss, ever since there was a trial that was recently published in JAMA Neurology, looking at the efficacy of bariatric surgery versus community weight management intervention for idiopathic intracranial hypertension. And it's clear from that study that rapid weight loss significantly improves the opening pressures. By way of that, we do see improvements with headaches. We see improvements with in papilledema as well. So in one sense, I do feel like weight loss is the silver bullet for IIH. So if somebody has like grade 1 or 2 papilledema, we will try weight loss before referring to stenting. But if it's vision threatening, grade 3, 4, 5, then we proceed with intervention, as quickly as possible, because then you're getting to that vision threatening level. But no matter what, after stenting or before stenting, I always make sure to refer the patients at least to a dietitian or somebody that can help them get on the road to weight loss, because the patients that I see that come back for a repeat stenting or where stenting is not successful have been the super obese, BMI greater than 50, they need to get on that weight loss if you're really going to have meaningful, improvement and everything. So that's kind of my algorithm and my thoughts regarding weight loss.
Yeah, I agree with you. For those patient recurrence, very much related to the sustained the high BMI or continue to gain weight, and those scenario happens, I'm sure, share the same thing. One thing to add on is for all scenario, if a patient have all the symptoms that the neuroophthalmology exams confirm, and those scenario, if MRV suggests patient has stenosis, we proceed everything as one procedure as well. That's a typical what we do. That's the reason end up with doing all this undergenerate anesthesia once for most of the cases undergenerate anesthesia one setting. So
Yeah. one thing that, because I'm just thinking about my experience, I'm thinking about when have I seen patients with some papilledema and like no gradient. And, one thing that I have noticed is that a lot of times the patients had a large volume LP, like within like 2 weeks of the procedure. So I guess have been making exceptions. I will stent without a large gradient if they clearly had IIH, papilledema, and maybe recently they had a large volume LP that's could potentially make the gradient, disappear. But I was wondering, did you like look at that? Was there any relationship between timing of LP and the gradient?
So the interesting part is that we try every effort not to drain CSF.
Okay.
Lumbar puncture is always open pressure only. So that's one part. A second part is since we have a large group patient had an angiogram done before, so when we look anatomically, they really didn't see much of changes. But I agree with it, the stenosis is dynamic, and that is one big deal. It could influence, particularly in those patients pure the venous sinus stricture, meaning from the narrowing from most likely related to compression. Those could result, potentially could be a problems. So that's why we never do at least after lumbar puncture, we don't do any procedure until at least a week because it takes 7 days to plan for during antiplatelets anyway.
Yeah. And I think one thing that Dr. Chen had pointed out, I think it's important for the general neurosurgical community as well as like, trainees who are listening, that the stenosis of the vein, it's not due to like some clotting or anything like that. It is extrinsic compression of the sinus from the brain due to, I don't know, some interstitial fluid retention. We don't really know. And there is clear like MRI evidence. If you look at a coronal T1 image, you can actually see how like the temporal occipital, lobes are actually pushing into that transverse sigmoid sinus groove and causing the compression. So that's just something that and that's why it's so dynamic, because it's nothing wrong with the vein itself. It's the brain that's doing the pushing. So, but do you guys have any questions?
Yeah, that's probably how they get encephaloceles and spontaneous
exactly.
Yeah.
I had a few questions, and we were talking about different practice patterns, and particularly I was interested in different ways in which these gradients are being measured. It seems there's not really a big consensus in the literature, and I've always been taught to measure them with the patient awake and at as much normal physiology as possible. And I was surprised to see that you performed all your measurements under general anesthesia. And there's some literature to suggest that the general anesthesia lowers the gradients. So I was wondering.
I think you're not the only one. You're not the only one. We went through this entire peer review process doing that. That's one of the biggest critique to ask on that. There's several things about this. Before I go anywhere, is one thing good about this is because all under the same math measure. So the entire concept based on is that the pressure in the venous sinus could change by changing the position of the patient, changing the anesthetics in terms of general anesthesia, ventilation, blood pressure. That's known problems. But the question coming down to what happened in the target area, meaning the target stenotic portion, which is typically, I would say 98 to 99% occur at the transverse and sigmoid sinus junction. Now, very interestingly, just about a week ago, there's an article just published, very well-written paper by Dr. Kyle Fargan, who's published on Journal of Neurointerventional Surgery. You guys should check it out. It's very well done, did an entire assessment of 174 cases. These cases from Winston-Salem. And to measure the pressure, venous sinus pressure before, without under conscious sedation, and then measure the pre-stenting and the post-stenting venous sinus pressure again under general anesthesia to compare what the difference is. It almost directly answered the question you raised. So the changes were significant in the superior sagittal sinus without general anesthesia versus general anesthesia before stenting. Sagittal sinus dropped about 2.6 millimeter mercury after general anesthesia. And that's important. However, there is one critical point is that at the transverse sinus, the sigmoid sinus junction, which is vast majority of these cases being performed, the stenosis across the knotted portion of the venous sinus gradient has been consistent if you maintaining the end-tidal CO2 in the normal Copic state, as well as if MAP in terms of the mean arterial pressure less than 20 millimercury swing from the baseline. This is exactly what we did. In fact, our end-tidal CO2 has been very crucial about this, communicate with neuroanesthesia, that throughout the time, these patients, we maintain these patients at the baseline blood pressure systolic. We don't really even look into, at the beginning, we started doing that. We didn't even pay attention on the map. We pay attention to systolic being exactly the same, maintain that. At the same time, end-tidal CO2 we maintain between 37 to 40 millimeter mercury. That is what we stand. And so when they, in their paper, they suggest everything changed except if you maintain on that, the gradient will be the same before after measurement. That's what we thought. We've seen sometimes even swing entire pressure. I'm sure, Doc, you guys have done those before. We notice that some even before and after stenting might seeing the differences, the entire pressure, but the gradient always been consistent. That's what based on.
Yeah, you know, in all honesty, like I mean, I do all my stuff awake. You know, I never put people to sleep, but like, you know, in the end, if you have a consistent protocol and how you manage the patients, and you know in your practice, you know what gradients are meaningful and what are not, and you're collecting data on outcomes, and you know, well, now in this case, no matter what the gradient is, you're going to have improvement papilledema. Then it doesn't, I guess it doesn't matter how you do things. I mean, there's variations in practice patterns, and as long as we're, you know, honestly auditing ourselves and knowing that we're doing the right thing and getting the good outcomes, that's the only thing that matters. So I try not to be dogmatic about things. You know, I like conscious sedation because it's easier workflow, but I don't like it because, you know, deploying the stent is painful for the patient, but they are on propofol sedation. But then they're also on propofol sedation and they start snoring. And if they're super obese, they start desatting, and then everybody, you know, freaks out. I mean, like, there's pluses and minuses to everything. So, yeah.
I agree. I think the most important part for this, I think that it is crucial. You can't just do the procedure with stenting only based on the gradient.
Yeah.
I think in the end, the most important part, you must have objective element. That is, cannot be just headache and the complaint, some visual disturbance. I think that part can be very misleading. It is important, must have the objective element, and then the pressure gradient along with stenosis, that make sense to stent. That I think that I need to emphasize on that. You can't just consider just pressure gradient, have a 2 or 3, they're going to stent. That can open entire ugly Pandora box.
That is a very good point. Well, this was a wonderful discussion. I really learned a lot. And honestly, you guys were great guest speakers because you were very passionate about the topic. Haydn, would you like to give our final wrap up here at the end of the discussion?
Yeah, and I just want to thank all the panelists, Dr. Chen, Dr. Brinjikji, Dr. Huang. This was really a great discussion, and certainly a lot of things to consider, and clearly a lot of aspects of this treatment that still remain under investigation. So Again, thank you all for your time, and this concludes the November CNS Journal Club podcast.
Great. Thank you, everyone. Thank you, Dr. Brinjikji, Hoffman, and Huang. Thank you.
Thank you.
Thanks so much.
Thank you.
Take care.
Appreciate it. Thank you.